long enough history of more than 10 years at least in our setup of diabetes. You look for retinopathy, look for neuropathy. If these complications are there, then probably you are dealing with a case of diabetic nephropathy. If it is not, if it is only 1-year-old or 2-year-old diabetic and there are no other findings, think about a secondary cause and another cause of proteinuria. Then renal symptoms, edema, hypertension, hematuria, frothy urine, renal failure. This you have to find out. Constitutional symptoms like myalgias, joint pains, fever, they might tell you whether you are dealing with all those causes that we have discussed under the heading of hematuria. You can put them here also. And then symptoms of coagulopathy, for example DVT or renal vein thrombosis or pulmonary embolism. You should keep that in mind. Next one. And then rheumatological history of joint pains, drugs, non-steroidals is important. Malignancy. Remember that solid organ malignancy can give rise to nephrotic syndrome. A carcinoma in the colon, a carcinoma in the thyroid, a bronchogenic carcinoma. Patient can come to you with nephrotic syndrome. So elderly patients, if they come to you with proteinuria without any other cause, at least think about as occult malignancy. And I have come across many a times patients in old age who are referred to me with nephrotic syndrome. They have got a bronchogenic CA. You do an X-ray, you find a tumor there. Or they have a history of altered bowel habit. You do a colono and you find a tumor sitting there. So it is this malignancy that gives rise to nephrotic syndrome. So you have to keep that in mind, and history is very important. Certain drugs which are sold over the counter, herbal medicines, they are all known to produce proteinuria and nephrotoxicity. Family history of renal disease and exposure to toxins. Next one. A patient with proteinuria may have edema, so weight is important. BP may be high, fundus, fluid overload features. Next one. And this is a flow diagram to assess the proteinuria. If it is sulfosalicylic acid negative on the dipstick positive, but your boiling method of protein, sulfosalicylic, is negative, think about a transient proteinuria. You can confirm it, and if it is persistent, you think about orthostatic or permanent proteinuria. But if it is dipstick positive, dipstick negative, and on coagulation method the sulfosalicylic acid is positive, think about light chains or lysozymes. Next one. What labs will you do? Renal function and GN screening. That involves, I have already mentioned, C3, C4, eosinophils, hepatitis B, C, hemoglobin A1C, serum protein and urine protein electrophoresis to exclude myeloma, ANA to exclude SLE, and Doppler studies to see if the veins are not blocked because of renal vein thrombosis, and then you may do a biopsy, and there are certain indications for doing biopsy in nephrotic syndrome. Next one. The urine dipstick, how to collect the urine. I think this slide has come earlier also. Next one please. The urine should be quantified. Whatever protein is there, it should be quantified. And the ways to quantify are that you do a spot urine sample protein to a spot urinary sample creatinine ratio. And the normal ratio is less than 0.2. But if the ratio goes more than 2.0, then it is a nephrotic range proteinuria. And anything which is in between 0.2 and 2 is the subnephrotic proteinuria. So you can do a spot sample urinary protein to creatinine ratio, or you can do a 24-hour urine collection and you can estimate the degree of proteinuria. It is usually the third block on the dipstick. Next one. And this is the turbometric method, and it measures all proteins. Next one. And sweeter the proteinuria, the darker will be the coagulum in the tube. Next one. You can look at the urine sediment. If the RBCs are dysmorphic, then and protein is also there, then you are dealing with a GN-like picture. And in the urine you can see fat oval bodies and Maltese crosses, which I'll show you. Next one please. This is a fat oval body you can see under the microscope. It indicates intense lipiduria. It indicates nephrotic syndrome. Next one. And this is a Maltese cross under polarized light. You can see a Maltese cross. This again is a fat in the urine. Next one. So when to refer to nephrologist for proteinuria? You may refer everybody, or you may refer patients after evaluation for transient or orthostatic proteinuria if it is orthostatic or persistent, or if the diabetic has microalbuminuria, or the third option is don't refer them at all, just let God refer them. And then you waste, you can call a nephrologist, you can email, you can send paper consult, or you do not refer them till they are unconscious. Next one. Whom to biopsy? A diabetic, a non-diabetic with nephrotic syndrome, SLE classification. If your immunosuppressive therapy has to be given, you have to do a biopsy, because immunosuppressive therapy is toxic, and you can't go on giving toxic drugs without doing biopsy, without having any justification. Diagnosis of plasma cell dyscrasia like myeloma, and if the proteinuria is less than 2 grams, but the biopsy, the otherwise symptoms have not helped the patient. Next one. So more or less every proteinuria that is persistent and is non-glomerular, is non-orthostatic, may require investigations. Next one, please. How do you treat them? How do you manage them? Proteinuria is not just a marker of kidney disease, but a culprit in its progression. I think this part should be underlined, that the proteinuria is a culprit in the progression of kidney disease. We must control it. Even if you bring it down from 6 grams to 3 grams, still you have done a benefit to the patient. And you must treat the secondary causes of like tumor, like lupus, like diabetes, like hypertension. Next one. So the specific therapy will be immunosuppressive drugs like steroids, like cyclophosphamide, like chlorambucil, like cyclosporin, or fish oil in IgA nephropathy. And non-specific therapies, I think you are all familiar with the use of ACE inhibitors and angiotensin receptor blockers. Next one. So in diabetics, you control their blood pressure tightly, you keep their mean arterial blood pressure less than 92, and there are benefits in that. And next one, please. ACE inhibitors, there are various studies which have shown benefit, that they reduce the intraglomerular hypertension and therefore reduce proteinuria, because they selectively vasodilate the efferent arteriole of the glomerulus. So the intraglomerular pressures fall, the intraglomerular hypertension falls, independent of the systemic blood pressure, and therefore proteinuria is lessened. Next one. So is the case with angiotensin receptor blockers. Next one, please. So ACE inhibitors and angiotensin receptor. That's all what these slides say. Next one. Calcium channel blockers. There is not much benefit really from the non-dihydropyridine derivatives, calcium channel blockers, although they are better than the dihydropyridines. Next one. Lipid control. So these lipids which are high, they are also damaging to the kidney. They are filtered, they cause inflammatory cytokines to come and cause damage to the kidney. So it's important to treat the lipids, keep them in a reasonable range. Next one. Hemoglobin A1C should be less than 6, I would say, because it reduces the microalbuminuria significantly. The DCCT has shown that. Next one. Protein. How much protein to give to patients who have proteinuria? Whether you give them extra protein, no, it doesn't help. It only increases more proteinuria. You give them no protein, again it will cause malnutrition. So you may reduce it to some extent, bring it down to next one, per kilogram. You treat the edema, you avoid thromboembolism, but the maintenance anticoagulation is not recommended unless somebody has that, because this heparin will act through antithrombin 3, and if antithrombin 3 is not there, then it is unlikely that this heparin will act. Infections has to be controlled because they are more prone to infections. Next one, please. Next one, please. Next one, please. So blood pressure in diabetics should be kept less than 125/75, and you maximize the dose of ACE inhibitors and angiotensin receptor blockers over your subsequent visits. You try to give them maximum tolerated dose so that the proteinuria is kept on reducing. Lipid control, glycemic control, next one. Dietary protein 0.8 grams per kg, next one. So don't let persistent proteinuria go unquantified or unevaluated, and try to reduce it. Next one please, can we go on to the next presentation, which is nephrotic syndrome. And this is the definition of nephrotic syndrome. I think you are all familiar with that. Next one. And you can go on. I will just show few slides. Next one. Next one. This is the capillary lumen. This is the endothelial cell. This is the endothelial lining. This is the glomerular basement membrane. And this is the podocyte sitting with its foot processes on this side of the basement membrane. And that's where the urinary space is. And this is the mesengium. So all these diseases which affect the podocyte, which affect the capillary permeability, which affect the mesengium, would give rise to nephrotic syndrome. So you can have a mesengioproliferative GN which will affect the mesengium. You can have a membranous nephropathy, or you can have a membranoproliferative GN, or you can have deposition of IgA here called IgA nephropathy, or you can have just inflammation of the foot processes, fusion of foot processes like in minimal chain disease, or you can have a segment of the glomerulus affected called focal segmental glomerulosclerosis. So there are various ways that nephrotic syndrome is produced. You must try to identify what's the cause. Next one. This is the filtration barrier, the foot process, the basement membrane, the endothelial cell. That's where the protein filters out into the urinary space. Next one. So next one please. I will go on to the common causes of nephrotic syndrome. When you talk about nephrotic syndrome, what are the common? Now we are talking about primary nephrotic syndrome, when the fault lies only in the kidney and not outside the kidney, like diabetes, like systemic disease, SLE, etc. That I am not mentioning. I am saying nephrotic syndrome. And here we have minimal chain disease, we have FSGS, we have membranous, we have mesengioproliferative, and we have membranoproliferative. Of course, all of these can have certain primary causes and secondary causes. For example, rifampicin can give rise to minimal chain disease, but it is rare. So we think about as the primary diseases. Next one. And then systemic diseases, diabetes, amyloid, myeloma, cryoglobulinemia, malaria, leprosy, syphilis, HIV associated nephropathy, HAVAN, drugs like gold, penicillamine, non-steroidal, heroin, bee stings, insect bites, and tumors, they all give rise to nephrotic syndrome. Somebody asks you the cause of nephrotic syndrome. What is nephrotic syndrome? What are the causes of primary nephrotic syndrome? Next one. Minimal chain disease, 75% children, 20% adults. Membranous nephropathy, 40% adults. One cause is hepatitis B. Focal segmental, 15 and 10. MPGN, 5%. Others, 5. So that makes the total in children, that makes the total in adults. Next one, frequency wise. So what's the difference between nephrotic syndrome and nephritis or glomerulonephritis? If there is no hematuria generally, or if there is no compromise of the kidney function, we generally call it nephrotic syndrome. But eventually there is no clear-cut demarcation. All diseases which give rise to nephritis or glomerulonephritis can have proteinuria which is of this degree that it can be nephrotic. So those patients we call nephritic nephrotic. Next one please. I think it's going to be a very long discussion, and the time does not allow me to cover all three subjects in detail, and I will stop here. And if you have any questions, we can do it in 2-3 minutes.